Welcome to this week's session of the Global IPC webinar series. Today's topic is use of masks for prevention of COVID-19 transmission. My name is Katie Wilson. I'm an epidemiologist with the International Infection Control Program at the US CDC, and I'm helping to coordinate this webinar series. A few reminders as we get started today. As we'll wait for the slide to advance. Live translation is available for the session in Arabic, French, Portuguese, Russian, and Spanish by clicking the interpretation button at the bottom of your Zoom menu. And as a reminder, the Arabic translation is available on the German audio channel. If you have questions about today's topic, a team will be answering questions in the Q&A box, and please put your questions in that box. If you have questions about connectivity or logistics or continuing medical education, please use the chat function, and our Project Echo colleagues will be monitoring the chat. Today's session is being recorded, and your attendance is consent to be recorded. The slides from today's session and a link to the video recording will be on the weekly email announcements that are sent out on Sundays and also on the Project Echo website. Continuing medical education credit is available for today's session through the University of New Mexico, and the link will be available in the chat box at the end of the session. Lastly, we do collect registration, participation, questions and answers, and poll responses for this program. Your data is de-identified and kept confidential, and this may be used for reports, communications, surveys, evaluation, and to inform new initiatives, just so you know how we are using your data, and as an example, some of the maps that we are able to create based on this webinar. So with that, I will hand over the microphone to Fernanda Lessa, also from the US CDC, who will be coordinating today's session. Over to you, Fernanda.
Thank you, Katie. My name is Fernanda Lessa, and I am the lead of the prevention team with the International Infection Control Program at the US CDC. And today I will be co-moderating the session with my colleague, Dr. April Boller, who is the IPC lead with the WHO Health Emergencies. Before I transition over to April, for the first talk of the session, I'd like to ask our panelists to introduce themselves. So Dr. Mei Chu.
Yes, good morning, good evening, wherever you are. My name is Mei Chu, and I'm the clinical professor at the Colorado School of Public Health in the USA. And my role is being part of the IPC committee and leading research on masks and respirators. Thank you for the opportunity to join.
Thank you, May, for being with us today. Dr. Viviane Diaz.
Hello, everybody. I'm Viviane Diaz. I'm an infectious diseases doctor. I work in 2 private hospitals here in Curitiba with infection control. And now I'm the president of Brazilian Society of Hospital Infection Control. And I'm glad to be here, and thank you for the invitation.
Thank you so much, Dr. Diaz, for being here. And then I'm going to transition over to Dr. Jeff Peterson.
Good morning, good evening. This is Jeff Peterson. My role is with the CDC NIOSH, National Protective Technology Laboratory, which administers the United States Respirator Approval Program for NIOSH. So we do look at everything that is submitted to us for approval in terms of respiratory protection from all types of devices, from filtering face pieces up through self-contained breathing apparatus.
Thank you so much, Jeff, for joining us today. So now I'd like to turn over to our first speaker and my co-moderator, Dr. April Boller, who will be talking about WHO's advice on use of mask in the context of COVID-19. Dr. Baller, over to you.
Thank you, Fernanda. Can you see my screen?
Not yet.
Just check here. It should be, you can see the video, but not the screen. Oh dear.
There is a green button at the end to share.
Sorry for this. I'm not sure why it's not. Just hold on 1 second. I have it wide open here.
In the bottom of the screen, the green share button.
Okay, just 1 second here. Oh, looks like it's frozen. Sorry for this. Do you think you can go on to one of the polling just while I'm trying to fix this? One of the polling questions, would that be possible?
Sure, so let's try to do that. So we are going to start then with the polling questions, and we do that for every webinar series. And the goal of those questions is really to understand from the participants the practice in their healthcare facility. So I ask Echo IT to put up the first polling question. So the question is, what is the mask policy in your facility for source control in the context of COVID-19? And I'm asking you to check just one. All healthcare workers should wear a medical mask through their shift. Only healthcare workers provide direct care should wear a medical or surgical mask. All healthcare workers should wear either a medical mask or non-medical mask, which is a cloth mask, throughout their shifts. Only healthcare workers providing direct care should wear a medical mask or non-medical mask. No mask policy for source control at your facility or other. I'm gonna give 10 seconds for everyone to, 10 to 20 seconds for everyone to answer that. And I see that people are still answering, so I'm gonna give 10 more seconds. Okay, so Hannah, you can close the poll. Okay, so looks like that the majority of you, 74%, have a policy in your healthcare facility for all healthcare workers, regardless of providing direct care, should wear a medical mask throughout their shift. And then 16% said that can be either a medical mask or a non-medical mask. Okay, that's interesting and aligns with some of the policies in some of the countries, including in the US, where our policies, healthcare workers should wear a medical mask throughout their shift, regardless of providing clinical care. So next question. So the next question is, has your health facility been facing shortages of medical masks? And again, I'm going to give like 30 to 40 seconds for people to respond. Okay, 70% of the attendees already responded, so I'm going to close the poll. And 66% said yes, your healthcare facility at the moment is facing medical mask shortages, and then 34% no. So which I think that we expect, I think that those results. So thank you everyone for your response for the polling question. So now I'm gonna turn over back to April and see if she can share the screen. April?
Yes, can you hear me, Fernanda?
Yes, we can.
Okay, and are you seeing the screen now?
Yes, perfect, April. Go ahead.
Thank you so much, and apologies for that. So good morning, good afternoon, and good evening to all. My name is April Baller, and I work at WHO as the IPC lead for the health emergencies. Today, I have the pleasure to present this very brief summary of the advice on the use of masks. And just like to acknowledge that there's a big team who've been behind developing this guidance at WHO, both at HQ level and all the regions, and that this guidance was also developed in collaboration with the Guidance Development Group, which include up to 40 external experts, many of them who are on the call today. So it's a really great pleasure and an honor to be able to present this on behalf of a big group of people. So I have nothing to disclose. So just to give a bit of background, this is the third update of the use of masks. The first one, which was done back in January, then there was another one that was done in April, and then this one which came out in June. This focuses on the use of masks in different scenarios. It looks at healthcare facility settings, it looks at the general public, and then also specifically in the context of people who are taking care of COVID patients at home. And it's intended to be used by decision makers, by IPC specialists, healthcare work managers, and health workers. And this guidance provides updated information. There's a lot of interesting and really important information with respect to evidence on transmissions for symptomatic, pre-symptomatic, and asymptomatic infections. And it includes information on when, where, who, and what type of mask should be worn in different settings by various populations in the context of COVID. Today, we're not going to look at the evidence. We're just going to look at what are the key messages, and really wanted to bring this out right up at the front. So these are the take-home messages from this guidance. The first one, very important, is that masks are part of a comprehensive package of measures to suppress transmission and to save lives. Now, masks should not be used alone as they are insufficient to provide adequate level of protection. The package of measures, which include, there's quite a few of them, but the most important ones are that people who have symptoms suggestive of COVID should seek help. They should stay home while they seek help and get guidance from their health provider. Suspect cases should be tested. Confirmed cases should be isolated. It's important to keep a 1 meter distance when people are outside, to frequently clean hands, avoid touching the face, and if using a mask, avoid touching the mask. And lastly, and very importantly, is the community should be well informed about COVID disease and be engaged. Without the engagement of the community, there's nothing that's really feasible. So that's for the first section. Another key point is that there are elements of the guidance that have not changed from the previous one, in particular in healthcare facility settings. For management of suspect or confirmed cases of COVID, contact and droplet precautions remain, which is the medical mask, the gowns, the gloves, and eye protection. And in specific settings for aerosol generating procedures, the respirator needs to be worn. And also to remind us all that for the general public, the risk-based approach remains the same. Now, this risk-based approach, just to remind us all, is focusing on 6 criteria, which include what is the reason for using the mask. This is for the decision makers when they're making a decision. You know, why are they asking the community to wear the mask? What is the risk of exposure to the virus for the community and for individuals? For example, what are the occupation of individuals? What is the vulnerability of the mask wearer? For example, are they immunocompromised? What is the setting in which the population lives? What is the feasibility of actually using masks, the cost of masks? And I know this is something that will be discussed in much more depth by our colleagues later on. And what type of mask is being suggested? And the third and key point that coming from the guidance is with respect to medical masks. So who should wear them? What is the priority? The priorities remains the same. Health workers all over the world, anyone who has symptoms suggestive of COVID, and people who are caring for cases. In addition to that, some of the new areas right now are really around the vulnerable population that we mentioned before. So people who are age 60 and over, and people with underlying health conditions. And this is based on the underlying risk factors which have been identified over the period of time. So the updates are specifically in areas where there's widespread community transmission. This is a key point. Healthcare workers should continuously wear medical masks throughout their shifts in clinical areas. Now, for the general population, there is much more advice on the settings and scenarios and the types of masks to be used. And then the third key update is linked to the fabric mask, also known as non-medical mask, based on research that has been done. So if we'll move quickly onto the healthcare facility setting, here, this is really just to understand and highlight that in many settings, universal masking is something that is already being recommended based on the risk of transmission and trying to reduce this transmission within the facilities. So having taken this into consideration, taking into consideration the evidence, preferences, and values on preventing infections within the facility, the WHO, under the guidance of the GDG, has advised that there should be targeted continuous medical mask use. And this really means that the health workers should be wearing a mask when they're in any clinical areas throughout their shift, whether they're seeing COVID patients or non-COVID patients. And there are particular areas within the health facility that are important, which have a higher potential risk of transmission, such as triage and emergencies, and also in long-term care facilities. And here we have, this is also in the guidance, but just to remind us all, this is looking at the different transmission scenarios and what are the type of masks that should be used and who should use them. So here, in particular, what we're focusing on today and what I mentioned earlier is the first row here, which talks about healthcare workers in a facility who are seeing patients in anywhere, in any activity, whether or not they're seeing COVID or non, they should wear the medical mask. For personnel who are working in the healthcare facility who are not having any exposure to patients, they do not need to wear a mask as long as they can maintain the 1 meter distance. There's also a section which looks at what one should do when one is in a transmission scenario, which is sporadic or only clusters, so not as many cases. And in this point, the risk assessment, the risk-based approach is what is used. And here, once again, I won't go into this in the interest of time, but this is really also just re-emphasizing some of the things we said earlier. Now, for the general public, what is the changes? So really, once again, it is linked to in areas where there is community widespread transmission in certain settings, scenarios, then there is now an advice for that government should encourage the public to wear these non-medical, also known as fabric mask. And we'll go through that. And just to highlight what are some of the advantages and disadvantages. The advantages of the use of mask is about reducing the potential exposure from an infected person to a non-infected person, also reducing the potential stigmatization of people who already have to wear a mask, and to make people feel that they have a role to play in stopping the spread, so empowering the community. So here we have, this table is also in the guidance, and it looks at some of the scenarios in which the mask could be encouraged. In particular, the point here is that when physical distancing cannot be maintained, when there's a congregation of a lot of people in a crowded place, and there's many examples of this. This is really the time when they're now suggesting that non-medical mask should be encouraged in this setting. Another example is on public transport, for example, taking the bus. And then finally, for the vulnerable population, that they should use a mask, but for them it is a preventative measure. In the other situations, it's much more for source control, meaning that a person who is infected, to prevent them passing on that infection to someone else. But for the vulnerable population, they should use the medical mask as a preventative to prevent them becoming infected. So this is really it for the general public and the update in the guidance with respect to that. And then the final part of the guidance really talks about an area which is very exciting, a new area which has been, thanks to the collaboration of, I know Mei Chu is on here, the University of Colorado, Stanford, and other colleagues. This has been an area, a request that was made from WHO, and all the scientific results were shared, and this is ongoing research, and it now looks at the type of fabric mask which should be encouraged when they're looking, countries are looking at actually developing these masks. So it's looking at the type of material that should be used, the number of layers, the combination of materials, the shape of the mask, how it should be coated, and then how it should be maintained. And here you can just see a picture. There's videos on this, infographics on this, which can be found at WHO website. And here, just to go into briefly a bit more detail, where you can see the different types of materials that have been looked into and how much of a barrier each of them provide. The important take-home message here is that it's not just that they're a barrier, but they also have to be breathable for the person who's wearing them. So based on what is known as the quality factor, the Q factor, this can help governments and decision makers decide on which are the type of materials that are preferable to be used. And also this was done taking into consideration resource limited settings where there are certain materials available and others that are not. And then finally, just more on the practical considerations. So if people are using the medical mask, gives a quick summary of what are the type of fabrics they should be used, how they should be put together, and importantly, how they should be managed. One of the key points here is that the mask should only be used by one person, and that when people go out, it's important that they take with them a plastic, some type of a plastic bag with a seal where they can put them in case they become soiled. And then the importance of maintaining it, washing them, and reusing them. And then just quickly, finally, just to note that there's other areas of work now within the use of mask. And these are areas that WHO, in collaboration with partners, are looking at and will hopefully be coming out in the future, which is more specifically looking at what is the use of masks in children, what masks should be used during exercise, and then more extensive look at the different types of materials that can be used to develop a mask. And finally, just to wrap up, always important to follow the local authorities, even though the guidance provided by WHO is a guidance. It is for decision makers, but at the end of the day, it's the local authorities that have the final say. On that note, I would say thank you very much. And I would have the pleasure to present the next speaker, who is Professor Mitch Schauber. He's the director of the National Center for Infection Control in Israel and works at the Ministry of Health. With that, over to Professor Mitch.
Thank you very much, April. Thank you very much, Fernanda, for the invitation. It's a pleasure to be here. Are you seeing my screen? Is my screen visible?
Very clear. Thank you,
Great.
Mitch.
Okay, so my job is to talk about the Israeli strategy for masks as protective tools in confronting COVID-19. I have no disclosures. The objectives of today's talk are to describe Israel's policies for use of masks in healthcare settings throughout the pandemic to date, and also our policies for mask use in the community. And finally, to discuss the impact of these policies on infection rates. So a little bit of background about Israel real quick. We're a population of about approximately 9 million people. There is universal healthcare coverage for all citizens. We have approximately 16,000 acute care hospital beds, about twice as many long-term care beds. The Ministry of Health is the central regulatory health body, and it has jurisdiction over all healthcare institutions, inpatient and out. The current national mask policy, July 16th, 2020, is that in healthcare facilities, medical masks are required across the board. That could either be a surgical mask or an N95 or equivalent respirator, depending on the circumstances, which we'll discuss. But everybody in a healthcare facility needs to be masked, and that means patients, visitors, and staff, of course. In the community, there is also a requirement for either medical or cloth masks in community settings. Now, it wasn't always this way, and I want to show you briefly how we got here. So here's our timeline. We started as a nation to prepare for the arrival of the SARS-CoV-2 virus in January, and for the paradigm until and through March 11th was to presume that this would be a pathogen that would be transmitted airborne, droplet, and contact route. So all three requirements needed to be in place when caring for confirmed or suspected patients with the virus. And as far as masks go, that meant that an N95 or equivalent respirator would be required for all healthcare workers treating such patients. That changed as of March 12th when new guidance was issued. This is based on internal discussions as well as the assembled evidence to date from the world, where our paradigm shifted and we realized that airborne, while it may in certain circumstances transmit by the airborne route, this was not a primary means of transmission, and therefore our guidance adjusted to focusing on droplet and contact precautions, and airborne just in certain circumstances. So that meant, as far as masks, that now healthcare workers treating COVID-19 confirmed or suspected patients had to use a surgical mask. The N95 was reserved for treating patients who were undergoing aerosol generating procedures or requiring ventilatory assistance of any kind, which we used as a surrogate for a patient who would be or may potentially be in the future needing aerosol generating procedures. And where these patients were taken care of in a mix of some undergoing AGPs and some not, the requirement was that N95s be used so that healthcare workers wouldn't have to change back and forth different types of masks during the day. That wasn't the end of the story. On March 25th, an additional guideline was issued due to continued spread in and out of healthcare facilities of the virus at this point. a mask was now required as of March 25th for all comers, all entering healthcare facilities, whether it be patients, staff, or visitors. And that has been national policy since March 25th. Now, where was Israel when this mask policy went into effect? That's a very relevant question. And the answer is we were heading rapidly towards a lot of badness. And I'll show what that means. If we look at March 25th, the date of the last mask update that I've given you so far. So this is our epidemic curve of the first wave, beginning in mid-February. Our first case was diagnosed on February 21st, taking out through the end of May. And you can see that on March 21st, we were still heading rapidly uphill in the count of daily new cases. And on this day, on March 25th, there were a cumulative total of 2,369 cases. Again, just a little bit over a month after our first case was diagnosed. The number of newly diagnosed cases on that day was 439. In addition to a general overall high number of cases, the healthcare workers were very predominantly affected, both in terms of the numbers of healthcare workers infected and also those forced into quarantine by exposure. So on March 25th, there were almost 2,500 healthcare workers in quarantine due to exposure. And in the week leading up to March 25th, there were 108 healthcare workers who were newly infected, where the infection was attributed specifically to the place of work or unknown. The one-day peak during that week was 22. That's a correction from 25, which I mentioned in my May talk for those of you who were part of that also. Now, we didn't stop there. The country didn't stop at masking in healthcare facilities. The next focus of intervention, due to rising rates of infection and as a measure to prevent transmission, was the community. On April 1st, our Prime Minister appeared on national TV, and he urged the public to start wearing masks. Some had already been doing that. It became a national mandate as of this announcement on April 1st, and it was quickly translated into law that was announced the following week, and it went into effect April 12th. As of April 12th, masks have been required by law outside the home, with a list of exceptions: young children, those who have a physical or mental disability preventing them from using masks, people alone in an enclosed space who don't need it, if you're exclusively with members of your own capsule, who you're living with and working with closely, if you're broadcasting on the media and you can keep 2 meters of distance from those around you, if you're two workers consistently sharing the same workspace and can keep 2 meters of distancing, and if you're participating in sports. But there were other restrictions placed on sports to prevent transmission. So at the time that the government issued the mask law, the Ministry of Health made available some community masking resources. And this is taken from our Ministry of Health website. And I've actually dedicated a separate slide for this if you want to take a screenshot and go on and look at this resource. I've given you the English up here. It's also translated to Russian, Spanish, French, Arabic, Hebrew, and Amharic. So, and on the website resource, it describes the Mask Development Project, the joint venture of the Ministry of Health, the security establishment, and textile experts in Israel, with the goal of promoting production of high quality, Ministry of Health approved reusable masks for the general population. There's no requirement that the mask you use in the community be Ministry of Health approved, but it helps if you want to market it and say that you have a Ministry of Health approval. There is a mechanism for doing that. The website describes the whys, whens, and hows. Why should I wear a mask? When should I wear a mask? How should I wear the mask? It's all there. And it gives instructions that are commonly asked questions. Okay, can you reuse it? Yes. And when you take it off, you need to not touch the middle of it. You have to keep it in a clean plastic bag when you're not using it. Clean your hands after you touch the mask and try not to touch it. How to launder it and how to dry it. And that you should clean it after 12 hours of use or at the end of your workday, whichever comes first. There's a production manual that's available and downloadable from the site with a whole list of table of contents, which includes the approved fabric types, how to cut and manufacture, how to wear it, how to get it approved, and all of the information that you might want if you're looking to either manufacture masks or buy masks that are ministry approved. Now, as April said in her earlier talk, masking is never a standalone public health measure. And it certainly in Israel, it wasn't. It was part of a multi-pronged approach to prevent transmission. At the time that we were putting in these masking measures into place in March, April, there were also other assorted lockdown measures, which are unfortunately familiar to many citizens of the world right now, which were progressively instituted: closing of schools, closing of other institutions, closing of a lot of what we live in the public domain. And also implemented were in healthcare facilities comprehensive personal protective equipment guidelines where masks fit into them, measures involving healthcare worker staffing and workflow in order to minimize staff exposure and infection and need to go out to quarantine. We also issued guidelines on determining the need for quarantine in the face of exposure, and the need for that, or the ability to avoid quarantine, is based in part on whether masks were worn by the exposed and by the index case. And finally, when it came time to talk about reopening and issuing a strategy for reopening, masks were, of course, required in the context of institutions that would reopen. So how did we do with this? Well, initially very well. We look back at the epidemic curve of our first wave. You can see March 25th, which is the last date of healthcare facility related mask guidelines that were issued, and we're rising rapidly. On April 1st, the Prime Minister makes his speech on TV, and in April 12th, the mask in the community law goes into effect. April 19th is when we start our reopening, gradually continued over the remainder of April and May and June. And you can see that the numbers of new cases went dramatically down. In May, they were in very low numbers. And this had a salutary effect also on the number of healthcare workers in quarantine. Remember this horrific figure in March 25th of nearly 2,500 healthcare workers in quarantine. By April 30th, that was down 89% to 260. Remember, we talked about the new healthcare worker infections that were attributed to place of work or unknown. In the week of March 19th to 25th, that number was 108. And by the same week, a month later, that number was down to 8. And so, as many countries did when the time was ripe, we started reopening. And the staged reopening began April 19th after the Passover holidays, with in the remainder of April, street shops, barber shops, other workplaces opening up. In the course of the month of May, gyms, malls, markets, museums, beaches, restaurants reopened. Houses of worship were able to reopen with limits placed on the numbers of worshipers and how they had to behave and keep distance and wear masks inside the facilities, the houses of worship. And schools reopened gradually over about a 2-week period where students had to come with a signed health statement, wear masks, and keep distancing. But as very bad luck would have it, during that reopening stage of the schools, a brutal and uncharacteristically for May long heat wave hit. And that made the use of masks, according to many, untenable. And so the mask requirement was temporarily waived, including in schools where climate control couldn't be attained. In June, the reopening continued. Reception halls were now allowed to house up to 250 celebrants at weddings and such, and rail service reopened. The first sign that things were taking a turn for the worse were in school outbreaks. Starting in late May, there were outbreaks in a number of schools around the country, leading to the need to reclose numerous schools that had just recently reopened. And there was a well-published, well-reported large cluster at One Jerusalem High School that involved well over 100 people, at least partially due to what is believed to be a super spreading event. And this sadly has proved a harbinger of things to come. If we look again at the full epidemic curve of Israel in terms of daily new cases from mid-February really through today, you can see that beginning with the end of May, we really entered a second wave that in terms of the numbers of daily new cases is so far dwarfing the initial wave. And the question is why? I mean, is is the conclusion from this, it's a rhetorical question, is the conclusion from this that masking isn't an effective policy? Well, clearly the answer to that is no, that's not the conclusion. There's a nice evidence review of face masks against COVID-19. It's a preprint. It hasn't yet been peer reviewed, but I suspect when it does get peer reviewed, at least one sentence in it is not, I don't expect the reviewers to have any problem with, and that is that public mask wearing is most effective at reducing spread of the virus when compliance is high, okay? Mask use, like, if you will, birth control, is good as a preventive measure only if you're using it. If your mask is in your pocket, if it's at home, if it's on your chin for that matter, it's not going to prevent spread of the virus. This is a scene in Israel in April, a demonstration where still in the thick of the first wave. People are some better distance than others, but they're all wearing masks. When you go to May, when the numbers are way, way down and complacency takes over in the country, you can see indoors, outdoors, daytime, nighttime, people are gathered, they're having fun, and they're not wearing masks. Even though it's the law, it was not effectively enforced. And I believe that now part of that complacency and that behavior has put us into harm's way. So in summary, Israel's masking policy underwent several revisions between January and April. Masks are currently required by all comers to healthcare settings and in the community. A combination of too rapid reopening, in my assessment, and inadequate assurance of implementation of non-pharmaceutical interventions, including masking, to prevent spread, have resulted in a second wave of infection that is now requiring additional restrictions or clamping down in an attempt to prevent continued spread. But universal mask use continues to be the primary item in the prevention bundle. So with that, I'll say thank you for your attention and turn the platform back over to the facilitators. Thank you.
Thank you so much, Dr. Schwaber. That was great and very powerful presentation. And thanks also for sharing all the Israeli resources with the participants on the cloth mask. So I would like now to introduce our next speaker, Professor Shaheen Metar, who is an infection prevention control specialist, Professor Emeritus of Stellenbosch University, and a founder member and the former chair of the Infection Control Africa Network, ICANN. Professor Metar is going to talk about the masking policies in South Africa and the rationale for it. Shaheen, over to you.
Thank you very much, and thank you for the invitation. Mitch, I really enjoyed your talk. I'm going to address this from a slightly different point of view, and that is looking at the great discrepancy. I think the whole of Israel could probably fit in the Western Cape. And we have this huge country that we have to deal with nine provinces and very, very different groups of people with a very diverse background. So if you look at this picture, it actually epitomizes what's happening in South Africa. There is the slum area, and there are the people that actually live the life of Riley and very, very well off indeed. I have no disclosures, but what we'd like to look at is the introduction of universal masking in South Africa, the rationale behind why we did it, and looking at the medical grade masks that we use in healthcare facilities. So the question is, of course, why did South Africa go for universal masking so early in the game? And we had our lockdown on the 6th of March, we had our first case. 25th of March, we had the first outbreak, if you like, because then it was still only 65 people. We decided that was the time to go into lockdown. And literally within 10 days after that, we decided to go in for universal masking. So by the time the government managed to sign off on the 12th of April, the concept of universal masking was in place. And the reason was quite simply this, that it is one of the most unequal countries in the world. It's very, very crowded, and social distancing is impossible. And I think for us to consider that in the concept of doing alternative non-pharmaceutical interventions, to see what is going to work. The bundle is really good if we can do all of it, but which parts of it can we do and which parts of it are difficult to do? So looking at the bundles, we've got social distancing, which is not always possible. There's a group of people that are lining up in the morning at the end of the month or the beginning of a month, getting their social grants. So the chances are very, very, very low of anybody socially distancing there. The second thing is about water supply, and what we know is that in the rural areas and the more difficult areas, we don't have water or everywhere. So water supply is about 83% of all the residences that we know of. Alcohol-based hand rub is expensive. However, now in public areas after the lockdown, it is available and it is used when one is using public transport or going into shops or into public areas. I must say the quality of it is really awful and terrible. So I carry my own. We could stay at home if you can, but if you're trying to find a way of earning a living and putting food on the table, there has been a huge loss. There's been a 7.2 deficit in our economy, and there has been a loss of over 100,000 jobs. The informal settlement, the informal sector is also very badly affected. So to stay home if you can, I think, is the way to look at it. But is there something we can do towards making sure that everybody wears a mask in public spaces? And this has now become the law. Like Mitch mentioned, that it's not always implemented, it's not always made sure that it's happening, but the law is there and we try and push it as much as possible. So the evidence that we had to present for this is quite clear. And for those of you that can see, I hope you can, this is looking at the mortality by May 9th per million population, and just showing the red line where there's no mask countries versus masking by 16 to 30 days when the outbreak was started in that country, and where the countries had masks within 15 days. Now, the one thing which is interesting about South Africa is that we have over 350,000 cases, but our mortality rate is below 2.3%. This again is looking at the overall global picture, where the green is where people are using masking. The red is where they don't recommend it in these areas around here, including Australia, and then in the United States where they have some cover, but not all of them. Again, this is also very interesting, where it shows a study by Ferguson, where it looks at the impact of public masking. And it says, and this is a nice graph showing the adherence. So as the adherence goes up to 100%, and the efficacy of the mask is not bad, and I'll address that with cloth masks soon, you will actually find that you can actually reduce the RO, which is the reproductive time for transmission. And this is something that is very much what Mitch was talking about from Jeremy Howard. What he said was that if universal masking is introduced, 100 cases at the start of a month becomes 31,280 cases by the end, or it can be 584 cases, which makes a lot of sense. And we've certainly gone with that policy. So our policies are, we have the Ministry Advisory Committee, and we are producing a huge number of documents, perhaps more than people can keep up with at the moment. But we have recommended that everybody wear a cloth mask in public. We don't want them to use N95s or surgical masks, because we need those for healthcare workers. Obviously, hand washing, social distancing are very, very important indeed. So in the poorer communities, in the townships, and it's very difficult to do that. But so we have now, this is the second document that's come out about wearing cloth masks. Okay. The compliance levels to this are very interesting. Even though we are now widely advertising it, there is a cloth mask production, which has got a particular setup, and we sent a set of these masks to May-Chu to have a look at to see whether they're useful at all or not. And we are providing these free for anybody who can't afford it, starting with the Western Cape, but moving out. And to date, this organization, which is known as WOW, which is Wellness of Well-Being, can't remember what thing stands for. This is actually with the Ministry of Health in the Western Cape, and they're the ones that are pushing it. But there's also advertising like Heroes Wear Masks, and we're trying to get people to show socially distanced. And this looks a little bit better than it was when they went to get their social grants. So a lot of that is going on. So the question is, and this has come up in your Q&As just now, does it have any protection? And I do remember in the beginning of the WHO GDG meetings, there was a huge discussion about whether we should or we should not. We in South Africa at that point decided we have to go for it, whether we think about it or not. And we looked at the models in the Far East, like Singapore, China, and South Korea. And of course, by this time, there were some publications that helped us, as well as work that was done by Mei Chu and others in the United States and other parts of the world. And basically, they were saying that, look, if you've got a decent amount of fabric layers, you will get good sort of filtration from that. And so we opted, and I'll show you what we opted for just now. And this is a nice one depicting the fact that you can have aerosols, which will be caught here. Then you have mechanical filtration. And of course, there's the electrostatic filtration, which has been widely publicized by Professor Choi. But the problem is this. If you don't have your masks fitting properly, and the contours do not work well in the sense that they don't hold the mask well, this is a huge, huge problem, not just for cloth masks, but also for respirators and so on. And therefore, we look at something that we made sure that when we were setting up our mask policy, that this would be a very strong indication from the government. We said we would, the slogan, as you all know, is I protect you, you protect me. So you will be making sure that your droplets don't go out when you wear a cloth mask. It should be, and so the other person does the same, so that in the environment around you, the amount of virus particle is much lower. This would be done by breathable, it's supposed to be heat resistant, it should be malleable so you can move around, and they should have 2 ties. But I will come back to this at the bottom here. And you should be just conscious of breathing, but not feel completely out of breath. Now, the idea is that it should be designed to stay above the nose. And what I see is on TV and so on, many of the ministries and other people, they wear their mask, and as they talk, the mask falls down because it looks like a very firm sort of material that it's made of. For this reason, they have to keep pushing and adjusting it up and down all the time. And then when they take it off, they don't know how to take it off. So if you look at this young man here, he's the classic example of somebody who thinks they're wearing a mask. And the nose is sticking out on top. And as we know that this is, of course, not the right way to wear a mask because you can inhale a lot of viral particles if it's within 1 meter. And also sometimes this hoop around the ear pulls the ears forward and it causes a lot of stress on the jaw. So this is it's quite important that we look at, our designs, and we went for the 2 layers of thick cotton with polypropylene spun bond inside and with ties in the back, so that you have to move your hands back if you want to take off your mask. You can't take off your mask from the front. You can't touch it from the front. It has to go to the back. And our advice is that you have a little back box next to your door. As you come home, you take off your mask, drop it in there, wash your hands, and the usual stuff that Mitch has also addressed. So now, when should you wear a mask? Well, we've said, as everybody else has, that you go shopping. But this is the big issue. In South Africa, for some reason, the Minister of Transport has said that domestic taxis should be 100%, can go to 100% occupancy, which we are very, very against. This is a closed box. There are lots of 1835, whatever number of people. And as you can see here, they're all talking and chatting, fiddling with their phones. This poor lady sitting in the corner near the window, trying to keep her head away from everybody. She's the only one who's masked in this situation, and she's trying to keep herself safe. So we think that there's been considerable transmission taking place in these taxis, particularly because there's a lot of local transmission taking place in South Africa. And also, we've said in healthcare facilities, you will arrive at the healthcare facility with a cloth mask if you are if you're a member of the community. If you're a healthcare worker, you will change to a medical mask if you go into the clinical areas. And then before you go home, you will put on a cloth mask before you go back again. We are trying very hard to get our taxi people to take responsibility by saying that you will not allow anybody on if they are not wearing a mask, and you will provide hand sanitation and sanitizing inside the taxi itself. This is something that you all know, but just to say that the 5 golden rules of not spreading the virus still goes everywhere. And then we give them another one, which is about how to put it on and what to do while you're wearing a mask and take it off, and what a good cloth mask is made up of and how you should deal with it. Okay. And this is a really good paper. This is in April, actually. And it clearly showed that by each additional cloth mask, you could save a lot of money, up to $3,000. Each of these cloth masks would also be great benefit to the healthcare workers, and of course we would try and work towards reducing the shortages of them. So if I could now move on to the medical masks. The WHO recommendations are very clear, and these belong to the American, which is F2100, level 2 to 3, and the EN, which is 14683. They are used for droplets. So if you look on the inside of them, there is a layer of polypropylene spunbond. They're not 4 or 5 layers. The outer part of it is water repellent or water resistant, and the inner part of it has got no activity apart from filtration that it had. So it's got nothing serious going on there. And it's very important to remember this, because there came a time when people were using their masks inside out. They were using the blue side against their face, thinking that they were protecting themselves, but they're not. So this mask functions only in one direction, and that is from out towards you. If you flip the mask, it's not going to help at all. So we're looking at something that's fluid resistant, that no fitting is required. Okay, that's nice. You can wear it for as long as you don't find it to be damp, which is sometimes up to 2 hours, but I've seen in some areas to be used much longer. Once you remove it, you have to discard it. It's really not worth putting it back on again. And I think that's a very important point, because where we had outbreaks taking place in amongst the healthcare workers, we found that they chose to keep their medical face masks with them. We use them in all areas of health facility and all healthcare workers, both clinical and non-clinical, and they have to be used in that sense. Now, what we know about the SARS-CoV-2 virus is that it is about 125 microns. So if this thing gives you protection of fluid and the bacterial efficiency is about 3 microns, it doesn't mean, or the particulate filtrate of 0.1, it doesn't mean that it doesn't absorb some of this up to about 50 to 60%, because bacteria don't, the filtration doesn't happen. The virus particles and other particles move around. There's Brownian movement, so they get trapped quite easily. And a virus never travels alone. It's always got fluid around it. So the particle is much larger than 0.1 micron. It's usually about 0.5 to 2 microns. And the differential pressure is, of course, the breathing resistance that you have. So when you're looking for a face mask, please make sure that you understand what's going on there. Onto respirators quite quickly. We use these for aerosol generating procedures. Healthcare workers feel very uncomfortable not using them during those aerosol generating procedures. I think each country has got its own set of procedures. We know that a lot of the work going on in the surgical areas, and mainly in the intensive care areas, will require an N95 respirator or a respirator. Now here are the respirators, and here's one which has got a valve in it. These are the ones that must fit properly, and they should only be used by healthcare workers. Again, when you cut them open, you've got 5 or 6 layers of polypropylene spunbond. But we've got Mei Chu with us, and she'll tell us a lot more. And that is not any different to the duckbill one, which is made by Heliard. This is made by 3M. It's just the shape is different and the fitting is different. But what I would like to say that we have told our group that they will not be buying any N95 respirators with a valve, because they themselves might be either asymptomatic or pre-symptomatic, and they could be infected. And of course, when you expire, you could be sending virus into the environment where you're working with your other colleagues and healthcare workers in particular. So I think it's really important to understand this. When you buy your respirators, please have another look. We're looking at the viral particle. These are medical, and there are 2 types of respirators. One is medical, the other one is industrial. The 3M 8210, which is this one over here, which is now lying in front of a healthcare worker, is not designed for healthcare, it's designed for dust. It is the 1860 that you need if you're going to look at particulate and respiratory filter. And please remember that when you're buying your respirators. Also, we were very confused when we were doing purchasing here, so everybody had to look into this. There were things called PM standards, but in fact, PM is not a standard. It just tells you that this is the particles of 2.5 microns or smaller that can be, and this is again a dust particle. It's not for bacteria or for pathogens. The KF94 is a Korean standard by the Korean FDA, and the filtration is 94% of particles. The KN95 is a Chinese respirator, which gives you 95% filtration. The only problem is that in South Africa, it doesn't give us the fit that we need. It doesn't have a very good fit. So where we are using it, we would probably, there is a bit of concern amongst the healthcare workers about its use. Again, the WHO recommendations are quite clear. So are there any problems when you use respirators? Well, there are problems. One of them is if you use them over very long periods of time, it's a CO2 retention problem. Now, we have been using N95 respirators in South Africa for at least 20 odd years because of a high TB count. We have 1,000 per 100,000 population, but we don't use them constantly. For coronavirus, they're using them constantly. So they come on to duty, they put on their mask, their face cover, they do a fit test, or they do a face seal, and then they stay in that till they leave or till they're going off for their break. So we have now agreed that they must take mask breaks every hour, every 2 hours. We are going for reuse of the respirators like TB, single person use only, and the reprocessing of respirators. From our point of view, for our sort of outcomes in South Africa, there is no one reliable method that we found, but I'll show you some data in a minute, or which is effective enough for us to be doing this. We are very concerned that there might be more than one pathogen. So it could be more than COVID, SARS-CoV-2, it could also be TB, it could be something else. And you can see that if you wear them over long periods of time, it actually leaves a very indelible impression on you. So the question is that if I'm short of respirators, what do I use? And I'm giving you 3 options, which you may or may not choose to accept. First one is that we extend the use of the respirator for as long as possible, if not damaged, stored as we do with TB and safely. And normally we can make them last for about 3 days if you're using them a lot more than we do for TB. I would recommend you read this wonderful document that came out on the 10th of June from PAHO, looking at technical and regularity aspects of extending reuse and reprocessing of respirators during shortages. It is particularly aimed at low to middle income countries and is a very sensible document like most PAHO documents are. So the risk here is that you lose fit, you lose efficiency of filtration, and you could be touching it more than you need to, and therefore spread disease. The second option we are saying in South Africa, for a well-fitting surgical or medical mask, and we use a shield with it. The shield can be cleaned regularly. Of course, the mask is then discarded because we seem to have a lot more medical masks than we do N95 respirators or any respirator at the moment. And we have a huge backlog of delivery, of respirators that don't fit very well. So that is why we've actually gone for this alternative. And then finally, if you're going to reprocess, you need to reprocess against standards. And I'm not going to go into that, but there is UV and there's hydrogen peroxide and there's steam and there's all sorts of things. Each one of them have their pros and cons, which you need to look at. So summarize, we went for universal masking early in the epidemic, which is probably why our mortality rate is very low. The compliance is terrible, but we're trying to work on that. When restrictions relaxed and some of the non-pharmaceutical practices also went out with the window. So people thought that because we're now at level 3, that we don't have to do certain things, much the same as Mitch talked about. It's all to do with behavior change. The cloth masks are useful where social distancing is difficult. We don't expect people to wear them inside the house because they come within the same sort of area that they can share amongst themselves. Medical grade masks are reserved for healthcare workers, and we want you to make sure that when you're buying your face covers that you buy the right one for the right job. Thank you very much.
Thank you so much, Shaheen, and great presentation. You've got a lot of questions on the Q&A box for you. And I'm gonna go ahead and turn over just to ensure that we have enough time for Q&A to Kelly Hahn, who is an independent mask maker. And she's gonna describe to us how to set up production of high quality community cloth mask. Kelly, over to you.
Thank you, Fernanda, for allowing me to share my experience with you. My name is Kelly Hahn. I'm from Parker, Colorado. I'm an independent mask maker, a hobbyist seamstress, and costume designer. The masks I am making are constructed of 4 layers of fabric stitched together. The outer 2 layers are 100% cotton. I use contrasting fabric to differentiate between the front and the back of the mask. The inner 2 layers are polypropylene. I add elastic straps around the ears or fabric ties, depending on the user's request. And I also include a nose piece to allow the mask to tightly fit around your nose and hold it in place. Typically, these masks take anywhere from 15 to 20 minutes if made individually, but breaking each step apart can optimize production and output. You can make double the masks. Social media turned out to be an excellent platform for a grassroots community. Just by sharing my own experiences with mask making, I offered tutorials and provided how-to videos. I was able to leverage more help. My friends and neighbors rallied together to source hard-to-find materials, and they also helped with various steps of making masks, including washing fabric, ironing, cutting, and even my teenage boys helped sew. During the shortage of PPE, we had various organizations reaching out, just like this fire department seen in this picture. They requested use of these masks. I was also able to ship out to hospitals, healthcare workers, or healthcare facilities, police departments, and essential personnel. Everyone was in need of a quality mask they could rely on and reuse. When I put my orders together, they were packaged in clear bags with cleaning and care instructions. And for safety, all deliveries were made with no contact. I would like to invite Dr. Chu to speak about my next slide.
So thank you, Kelly. So this is the mask that Kelly Hahn shared with us for the demand study, which is a study to look at ways of decontaminating face masks and respirators using simple, reusable methods in low resource settings, and hopefully that study will be finished shortly. So we included that in that study, besides the medical masks and respirators that you've seen from Professor Shaheen and from also Professor Mitch Schreiber, is that we looked at to put these through the same type of testing. And quickly on the right-hand side, you can see that out of 5 of 6 samples, generally the efficiency right away by sodium chloride efficiency, and then later by bacterial filtration, that we can reach an efficiency about 44 to about 50%, and that the pressure drop was not very high and was very acceptable, therefore comfortable. If you were going to charge the spun bond, which is the 2 layers in the middle that Kelly speaks about, you can increase in efficiency, and that turboelectric charge can last for about 12 hours, and so it made it much easier. So, and this is the information produced by Dr. Yi Chui at Forsey Air in Stanford. So back to you, Kelly.
Thank you. This slide is really important. These are just a few of the many people who were a part of this grassroots community effort. Their help was so instrumental in helping me and so many people, both locally and nationally. If you'd like more information, I have provided some links at the end. Thank you.
Thank you so much, Kelly. And it's great to see that your mask was actually tested by the Stanford group and showing high filtration efficiency. So thank you for sharing your experience. So now we are going to go ahead and move to the Q&A. And the first question I'm going to ask Dr. Schreiber to answer. It is, and it has got a lot of media attention lately. Does COVID-19 require airborne precaution? What's the evidence?
So that's a very, very a lot to talk about in that question, and we're limited with time. I'm going to try to give you in a nutshell. It's, as you say, a very hot topic right now, and has been throughout the pandemic, but it's even picked up steam as we've gone along. As evidence has come in more and more, as I showed that in Israel, we have been persuaded by that evidence that indicates that the primary means of transmission is droplet associated transmission. Fomites and the environment where droplets may have contaminated as a means of transmission is very, very actively looked at right now. And we're still accumulating data on the importance of fomites in transmission. We have very convincing data on the importance of droplet transmission, and that leaves airborne. Airborne transmission is something that is a topic of a lot of controversy. The public health, infection prevention and control community, by and large, has been convinced that airborne transmission is not a primary mechanism of transmission of this virus. And I would refer everybody to look at the excellent summary put out by the World Health Organization just on July 9th. I can hold it up here so you can see what it looks like. It's available on the WHO website. It's I guess you can't see it, but it's the transmission of SARS-CoV-2, implications for infection prevention, precautions. It came out on July 9th, and it's the scientific brief. And it really summarizes nicely the evidence of the various means of transmission. The bottom line is that we presume on procedures that we know to be aerosol generating. We know that certain medical procedures produce aerosols like intubation, extubation, a whole variety of other procedures that are established. We insist on airborne associated controls, and that includes N95 masking, and it also includes a whole other bundle of ventilatory controls to prevent airborne associated transmission on the presumption that the virus transmits this way. We do not have convincing evidence that it transmits this way, even in airborne associated aerosol generating procedures, but even certainly in non-aerosol generating procedures. But those who argue against this point of view point to experimental conditions where aerosols, the virus has been found in aerosols, and to circumstantial evidence of mass spreading events indoors, the choir practice in restaurants elsewhere, where there has been a lot of people infected in a small period of time and in a small space that would argue circumstantially potentially towards airborne associated transmission. But there are other mechanisms, other ways of explaining those cases that have happened. And in the experimental conditions, we have yet to show that there's live infectable virus that has been produced in the lab that demonstrates airborne associated transmission. So therefore, to summarize, when we have non-aerosol generating procedures, we presume a droplet and fomite-based main mechanism of transmission. When we have, in a medical setting, when we have airborne associated transmission, we insist on airborne associated precautions, which include N95, but I just want to point out that it's not only N95. If you're assuming airborne transmission, you must assume that the air is contaminated. And if the air is contaminated, it means that everybody else in the area needs to also be protected by N95, and there has to be ventilatory associated controls in place also, whether that be negative pressure or other ventilatory controls. Airborne associated isolation precautions are a bundled approach. Thank you.
Thank you, Mitch. So I'm gonna go ahead to the next question, and Dr. Viviane Diaz, that's for you. What are the recommendations for mask type among environmental cleaning staff working in COVID-19 units?
Well, regarding the use of a mask for cleaning staff, these professionals should use the surgical masks associated with glasses or facial protector to perform the cleaning in general. But for the cleaning areas or patient rooms where aerosol generation may be occurring, this professional should use then mask N95 that is recommended.
Thank you so much. So I'm gonna go ahead to the next question, and that's for Dr. Jeff Pitzer. For countries with shortage of N95, are there ways to produce homemade respirators? What are the NIOSH studies on homemade respirators?
So in the States, we're in an occupational setting where respirators are required. So in healthcare, that would be situations as Dr. Schwaber presented, are, you know, where an aerosol generating procedure is being done or such that a respirator is mandated to be used by the Occupational Safety and Health Administration. So in those cases, you know, the CDC guidance in the US points to 3 levels. So the first is those conventional strategies where you would need to use a NIOSH approved N95 respirator. Then some of the contingency requirements are to step down then to respirators that would meet other international standards, such as the GB 2626 in China, or some of the Korean standards or others. And then, you know, the third level is certainly the fact that you can point to cloth face coverings and such. So those are certainly contingencies where there are no other available options. And in light of some of the work that NIOSH has done, we know that some of the cloth face coverings, when evaluated against the standards for N95s, provide, you know, efficiency levels from the mid-teens up to 30 or 40%. So, you know, certainly when you're needing to protect yourself as a healthcare worker from aerosols, you know, if there is nothing else available, you could certainly utilize a cloth face covering, but the first choice should always still be a respirator. And I think that, you know, we've seen many different types of cloth face coverings and homemade respirators hit the market. A lot have been evaluated, and a lot, you know, come nowhere near the meeting the challenge of being classified as a respirator and providing the same level of protection. And I think what's important here is, you know, when we talk about, you know, protecting oneself versus source control, there is not a lot of data out there that establishes whether respirators, masks, or, you know, respirators with exhalation valves provide adequate source control. So that's an area that NIOSH is moving to do work in.
Thank you. That's very helpful. So now I'm going to turn over to Dr. May Chu. So what are decontamination methods for N95 or medical mask for low resource settings?
So we have a study right now for 2 different types of decontamination that can be used in low resource setting. One is the spraying of a solution that it can be used to, it's a photochemical reaction, and then you can put it in sunlight, and then within 15 minutes to 30 minutes, it would be killed SARS coronavirus. And these experiments are being finished right now. And if that shows success, then it could be used and applied almost anywhere with just sunlight. The other method that we're looking at, which other groups have already studied and reported successfully in the killing of SARS coronavirus 2, is low dry heat. So that if you have a source of low dry heat, about 75 degrees centigrade, for about 30 minutes, it will also work. And so those are the 2 methods, as opposed to the vaporized hydrogen peroxide and versus some of the more expensive equipment intense methods being used elsewhere.
Thank you very much. So I will turn over to the next question. Professor Shaheen, how long can an N95 be reused? And what are the considerations of reusing without reprocessing of N95?
Thank you. We have a very high TB load, so we do reuse our N95 respirators because we have to use them everywhere, including the TB outpatients, inpatients, and so on. So we would use them up to a week. However, there's a very clear guideline. So the respirator belongs to one person. It's removed in a particular way. It's put into a paper bag, not a plastic bag. And it's got your name on it, and you keep it with yourself for as long as you use it. We have got two situations where the private sector has reprocessed their respirators. We have no idea how good they are. I totally agree with May. You know, heat is probably the best way of getting rid of this virus because it's such a sensitive virus. It really is a highly sensitive virus. And to zap it with all sorts of things is not going to be very effective, which also then destroys the respirator itself with the efficiency, the filtration, the breathability, and so on. So from our point of view, we are going to reprocessing at the prolonging the use at the moment rather than reprocessing.
Thank you very much. Professor and Dr. Jeff Patterson, anything from the US side that you want to add in terms of NIOSH studies on decontamination of N95s?
So I think that what we've noticed with some of the decon methods that NIOSH and FDA are considering to allow within healthcare settings, the first thing is that we as in NIOSH are concerned about, does the respirator continue to fit people, and does it continue to offer the implied protection? So, is the filter efficiency impacted? So, there are studies and work that has recently been done that show that there are some methods that can be utilized up to 20 times to extend the life. But, there again, a lot of the same controls need to be placed, on the device. So we need to, whoever's doing that reprocessing needs to keep track of the total number of times, whose mask it is. That mask needs to be reissued to the same person. So, from a decon side, that is correct. And then, from the hygiene side, certainly, even if you are reusing without decontamination, you should be paying close attention to, is the mask wet? Is it soiled? And if it is, it does need to be disposed of and replaced.
Thank you. April, do you want to go ahead and ask the other questions, or should I continue on?
I can do it. Can you hear me okay?
Sure, yeah.
Great, so thank you for that. So the next question is to Vivian. And the question is, can a medical mask be worn for more than 6 hours if it is not soiled or wet? And if not, why? Over to you, Vivian.
Thinking about optimizing the use of medical masks, they should be used continuously by the healthcare professionals until it's necessary to remove them for a break or for a feeding. But at that time, ideally, they should be discarded and replaced with new ones because it's very easy to contaminate, self-contamination. So it's better to discard this mask. And this interval will generally not exceed 6 hours because people had to feed and to drink water, things like that. In any case, medical masks must also be removed if they are wet, damp or damaged. And it's important to remember that when removing the mask, the professional must clean the hands immediately after. So this is the right thing to do.
Great, thank you so much for that, Vivian. And the next question is for Professor Mitch. What are the recommendations of face mask among children? Can you describe the evidence of effectiveness of cloth mask among children less than 10 years of age? Over to you, Mitch.
Okay, I think we by prior arrangement, we were gonna let Shaheen take a first crack at this, and then I'll go second. If Shaheen, if you wanna, do you wanna lead off with this? Or
I'll leave it to April. I don't know if she wants me to speak or does she want you to go?
Please go ahead.
Well, thank you. Okay, we had our schools closed, and we then opened schools about a week or so ago. And the whole issue around what to do with children is a big, big problem, and it needs to be addressed. So the cloth masks are definitely very clear for us. Okay, so what we've decided is that the children under 7 who are not going to primary school will probably not need to have any face covers for several reasons, not the least of which they can't handle it. They don't like their faces covered. And if you give them a face shield, they get very upset. So basically, they're going to have to work on another system. They're not very good at social distancing. Their hand hygiene is terrible, you know, so it's really not an easy one. They usually, however, then the transmission is much lower amongst them, but they can probably infect their elders if they come home to see their grandparents. The eldest ones are fine. I mean, the teenagers are like adults, so you can give them a responsibility to take care of their own face covers, and also if they're wearing a shield. We had to deal with children with autism and with disabilities who were actually deaf and had to lip read. So for them, we've recommended face shields. It hasn't been long enough with the schools open for us to actually decide whether that's working or not, but we'll come back to that. So the gap area, which is also the gap in the WHO group, is in fact between the 7 and 12-year-olds. We don't know what to do with them just at the moment. And we have opted for saying that if the parents, and this is really important, if the parents feel that they can send their children to school and they can prepare the child to go to school, to wear a mask and to understand what the mask is about, to go out and take a break every 2 hours, to understand about hand hygiene, and they come back home and they actually then take it off and do what they have to do the way they should do it, then the answer is yes. Okay. If they can't handle that, then I think we run into major problems with the children, because they do hug and kiss whether you like it or not, and then we run into a completely different set of problems. So the answer is, we know what to do with 2 extreme ages. We don't know what to do with the bits in the middle. If that's all right, April.
And what I would add to that, to what Shaheen has said, is that this wasn't always known in the course of this pandemic, but it is pretty well established now that children do get the virus and they do transmit the virus. So clearly, at an age where it's not safe to put masking on children, we have to find alternatives to prevent them from contracting it and transmitting. From the age where it is safe, they should be masked. And I said in Israel, that was from 7 and up. And it may also be, as Shaheen has alluded to, that of the masking and distancing paradigm, it may be easier to get kids to mask than to distance. But both are important, and where masking isn't feasible, alternatives, for example, face shields or other viable alternatives, have to be thought about in order to prevent children from getting the virus and from transmitting it. Thank you.
Thank you, Professor, both Professors Shaheen and Mitch. That was very insightful. Okay, so we'll move on to the next question. Mei Chu, do face mask or cloth mask work to protect the wearer against COVID-19? What is the evidence? Over to you, Mei.
So most of the time, thank you for the question. I think we are still trying to collect evidence about the wearer being protected, but we do know that any kind of barrier in the context of where you are in a situation where you cannot do self-distancing appropriately, that wearing this would be important. We also have seen these statements from others that if you're older and you're in a high-risk group, you should be wearing it to give yourself an added layer of protection. And that goes into the WHO guidance for risk assessment as to what you're going to wear or not wear. The answer is that if you look at the Schlerin videos and or some of the clever videos have come out, definitely if you were able to see the potential carrying of droplets to another person, that if you had a barrier on, you would be protected from inhaling it directly. And so there's some, visible evidence of that, but currently doing some of those measurements, especially with community masks from, I would have to say, from Israel, from South Africa, and from Brazil, plus other countries. We're studying that this next 3 months to look at the exhaling and the inhaling and particles and the risk associated with them.
Great, May, thank you. And that's really exciting research that we're all looking forward to hearing more about. Okay, so we have one more question in the interest of time before closing, and this goes back to Professor Shaheen. What are the recommendations in terms of mask use for protecting community health workers in remote areas of sub-Saharan Africa? And how can these masks be safely disposed of by the community workers? Over to you, Prof.
Thank you. It's a difficult one. So I can tell you what we're doing in South Africa. We started off on the wrong foot, really, and we've had to rectify that. Before we had local transmission in the community, and we were sending the community workers out to look at the screening program. We've done about 200, we've done over 2.5 million screening. They went out with cloth masks. But the thing I must raise is that if the healthcare workers don't feel safe in executing their duties, they do it very, very badly. So they came back and they said, you know, we're not doing this. This is nonsense. We don't feel protected. We don't feel this. And okay, fine. So we then decided that they could go with a medical mask, or they could wear a cloth mask and a face shield. And the reason for that is because we didn't have enough medical masks in the community side of things. We were trying to keep them for the healthcare worker side, in the healthcare facilities, I mean. And so we said that they could use it with a face shield. Some of them accepted it and some of them did not accept it. And they wanted to go with medical masks and a face shield. But as soon as we gave them face shields, they felt far more protected and able to go into the community. So the second part of this is, in an urban setting where there's a lot of local transmission, is very different to a rural setting where there is very little transmission. In fact, if you look at where our hotspots are, they're all around Cape Town, inner city, Joburg, inner city, KwaZulu, inner city, not really around the outside. So if they go into the rural areas and they, I would imagine, have a cloth mask and a face shield, both of which they can then reuse because they'd have to wash them and dry them and iron them and so on, then I would imagine that's probably okay and they could use those. The face shield, of course, can be washed and wiped as well. There's no evidence behind it. There's no, at the moment, we haven't been able to collect any data about this because of this total chaos that's going on, but this is what we see. So most likely those in the towns would prefer to wear medical masks because they also have access to it. Access is better. While in the rural areas, they might have either, but they can wear cloth masks with the face shields. I hope that helps.
And Shaheen, can you just talk about how they should dispose, if they wear the medical mask, how to dispose those?
Well, this is a huge global problem about how much PPE has gone up and caused a huge load of plastic in the environment. So the only way they can dispose it is to throw it in the red bin, in the infectious bin. That's what our lot are doing anyway. But there is a huge problem with the waste. We have seen a 40% increase in infectious waste just since March. So March, April, May. So that's costing us a huge amount of money to get rid of that infectious waste from the hospitals. And there's no other way you can throw it. You can't put it in any other way. I mean, there's nowhere else you can put it. You know, you have
Thank
to get rid
you.
of it.
So we are over time right now, so I'm going to turn over to Katie Wilson to close the session. Thank you very much for everyone. It was really great panel. I appreciate.
Yes, agree with Fernanda. Thank you to all of our speakers and panelists today for the great presentations and great discussion. As a reminder, the links for the CME credit are in the chat box, and you can click on those and receive CME credit. And we will be continuing this series next week, Thursday, July 23rd, where we will be discussing ventilation in healthcare settings in the context of COVID-19. So please join us again. And with that, we will sign off and thank you all for joining today for the great discussion. Bye to all.